Hello, everyone. I'm Maria Theodoulou. I am the Program Director of Breast Cancer Medicine at New York Oncology Hematology up in the Capital District. I am so thrilled that I have Elizabeth Morris with me today, who's the Professor and Chair of the Department of Radiology at the University of California, Davis School of Medicine. Um, I can keep talking about her, and it will take up all of the time that we have for this podcast. I've always considered her an incredible colleague when we shared space at Memorial Sloan Kettering Cancer Center, someone that I could vent to, that I could discuss difficult patient cases, and found her to be one of the most unbelievable patient advocates and true scientists forging the way of how women are being diagnosed with breast cancer. This program, all 13 chapters, are being truly presented to all of you from a grant from Stacy and Richard Rosenthal. Stacy, a patient of mine who's a 23-year survivor of a very high risk breast cancer diagnosis and really just wants everyone to share all the state of the art information. So, Elizabeth, hello.
Hi, how are you?
I'm not used
Good
to
to
calling
see
you
you,
Elizabeth,
Maria.
it's usually Liz.
Yeah,
So, welcome and thank you so much for being here today. You have continued to push forward all of the boundaries regarding breast imaging and hopefully early diagnosis of breast cancer in women, especially those women that are high risk. And I really want to spend some time talking about where we've been by way of breast imaging, uh, how we've started to move forward slowly by adding ultrasounds, understanding the importance of breast density, the evolution of MRI, and something that I'm really a champion for that we don't have up here yet. Hopefully, we will contrast enhanced mammography. So, why don't you take the field? You know, you're the author of over 400 papers and five
sure. Yeah.
chapters and a book that you wrote yourself. So, I'm going to give it to you.
I'm a huge passionate advocate of early diagnosis because I always feel that the earlier we can pick up a cancer, the less surgery has to be done, the less treatment therapy has to be delivered. So this is really, I think, focusing on the early diagnosis is really helpful for patients, not only for survival, but also for treatment options. So we have come so far in my career that over the last couple of decades, there is a huge advance in, I think, imaging. We are entering, I think, the era of contrast-based imaging, which I think will change the landscape on breast imaging. We came, I don't want to downplay mammography. I think mammography is one of the greatest inventions in the last, many, many decades and has saved countless numbers of lives, picking up cancers before they are felt, before they are palpable. But it has limitations, and every test has limitations. And the limitations on mammography are that there's women have various breast density, and the density on the mammograms are the same as the density of the cancers, and so therefore the cancer can be masked by the mammogram, and we can't see it. So that's why we need to employ additional tests to sort of see these small cancers. And luckily, we've seen the adoption of ultrasound, which is one of the tests that we can use to look at uh, breasts that are dense, and that has been adopted now throughout the country. But it was a real uphill battle, and it was a grassroots effort. And it didn't come from the medical community. It came from a woman, Nancy Capello, who was diagnosed with breast cancer, and she had dense breasts, and she couldn't understand how she could have cancer, and it didn't show on the mammogram.
And just for the
And
audience, Liz, I'm just going to say to understand density, if you look at the
yeah,
shawl that Dr. Morris is wearing on her shoulders, picture that as breast tissue, and you can see the oranges and the blacks and the circles and the dots and the angles. A small breast cancer can be missed in a pattern like that. All right, please, I'm going
absolutely.
to give this back to you.
And I think, and that brings up, I'm breast density is important, but it's not the only thing that we're looking at on the mammogram. And I think, Maria, you're absolutely right. There's patterns of the breast tissue that also come into play. That some kind of patterns are much more difficult to interpret and see breast cancers in. And some other patterns are very easy to see breast cancers in. So, this understanding that not everyone's breasts look the same, and I want to also say that breast density is only something that can be detected on a mammogram. So you have to have a mammogram first before you can understand, are you dense or are you not dense? Um,
I'm so glad you
so,
said that because I have so many women who come to me and say, "Why can't I just get an ultrasound?" And
right.
it's good to hear someone like you say that publicly.
Yeah, and an ultrasound's good, but does not replace a mammogram by any means. An ultrasound picks up different kinds of things than a mammogram picks up. The mammogram can pick up a mass or calcifications, whereas the ultrasound predominantly only picks up masses. Anyhow, so I think we now have legislation, and we now have in some states that insurers have to cover additional tests for women with dense breasts, which is a great thing that's happened. So many women are now getting diagnosed, I think, through these additional tests where the mammogram was negative. For example, there's a new Find It Early Act now that's come out in Washington, D.C. And I think it's based on the fact, and I think Katie Couric, who has gone public with her cancer diagnosis, and she had dense breasts, and her cancer was found on an ultrasound. So I think there's this sort of public as well as medical push to really investigate additional tests other than just mammography. Now, so ultrasound is great, but it's not as good as the contrast based techniques. And I call them contrast based techniques are MRI, and you mentioned it was contrast mammo. And those are two tests that can pick up cancers that both the ultrasound misses and also the mammogram misses. So there's been a lot of work to look at contrast-based imaging. And because it was initially done with an MRI, and MRIs are expensive and they're not very accessible, and there's not a whole lot of MRIs around, it was really only considered that only high-risk women should get MRIs because they were high risk and they needed to have earlier diagnosis, and the MRI with contrast could pick up these cancers before the
Could you
mammogram.
also just define for the audience high risk?
Yeah, so high risk is, well, you can define high risk probably better than me.
I'm happy to.
Well, I can define it from a mammographic or at least an imaging standpoint, because breast density is it 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 not only masks the cancers, but if you have dense breasts, you have a very slight increased risk for developing breast cancer. So we call breast density sort of like a double whammy in a sense. You have an increased risk of getting breast cancer, but you have a less of a chance of having it picked up on a mammogram. So that's why investigation into these additional tests is so important. But you can talk about the
Well,
genetic.
we know that there are epidemiologic risks. If you've had a breast cancer before, you're at higher risk of developing another breast cancer, certainly family history and first degree family members. Other cancers that might speak to not only the family history of breast cancer, but pancreatic cancer, ovarian cancer, where patients' genetics may need to be interrogated. And if a deleterious gene mutation is identified, that patient is at a higher risk. And it's not just BRCA1 and BRCA2 anymore. There's a wide array of breast cancer mutations that we try to identify. Certainly, there are lifestyle factors that can be concerning. Women who really exceed what's an acceptable amount of alcohol. When I say acceptable, I'm not talking about socially or professionally. I'm talking about the guidelines that go back probably close to 30 years.
Yeah.
That more than 3 drinks a day will increase your risk of breast cancer by 60%. And now we have all this uproar in the media that alcohol is a no-no when it comes to breast cancer, as if it's something new. We really have to be not only clear and educate on what lifestyle health is all about, holistic health. And I think we count on imaging to take the brunt of the diagnoses, and there's so much that we can contribute outside of the radiologic arena to help ourselves get to imaging quicker,
Yeah.
uh, and certainly keep ourselves healthy enough so if something is identified, it's all our healthy army of organs that will keep us as fighting ready as we can. Certainly, having a mom or a sister or a daughter with breast cancer, even without a gene being identified, um, really discuss your whole holistic history with your provider, whether it's a gynecologist or a family practitioner, so they can help guide you. And the onus on us, who are more academically oriented, is to educate the providers. I give the stage back to you.
Yeah, well, no, we're finding out, particularly now with AI and pattern recognition, that risk is a lot more complicated than even just the genes or the family history or the lifestyle risk factors that you just mentioned. So I talked a little bit about breast density, but there are new AI algorithms out there that show that the pattern. We talked a little bit about the pattern of the breast before, but that the pattern can also predict who is potentially going to develop breast cancer in the next 5 years or so. So these are tools that are coming out that actually perform better than the sort of the traditional risk tools that we have been using that are epidemiologically based. And so these are exciting. It's almost as if the image or the picture of the breast gives us a full history of the patient. Their pregnancies, their estrogen status, early menarche, or late, early
Late
or
menopause.
menopause, and yeah, and so there's definitely information in that image that can help us decide, is this patient high risk or not, or is it average, or is this patient average risk? And should we just be screening every year? And even in the future, I foresee that these kind of algorithms are potentially going to allow us to say, you're not that high risk, and maybe you don't need to have, breast cancer screening every year. Maybe it could be every other year, every 3 years or so. So these are exciting developments about risk, I think, and can help us sort of triage people, meaning saying that we should not be screening on a population basis,
Mhm,
that perhaps we should be screening on a personal individual basis
mhm.
and going forward. And so there may be some women who need to be screened more frequently with mammography. They may need to be supplemented with ultrasound or a contrast based tests like MRI or contrast mammography. So I think there's going to be different permutations and algorithms for each individual, hopefully for each individual woman in the future, so we can really pick up these cancers at the earliest point possible, so that we can save the most lives. So that's sort of the exciting, I think, research that's happening in the AI space with respect to risk and screening. But getting back to contrast tests, which is really, I think, completely these two tests. And as you said, contrast mammo is a lot newer than MRI. We've had MRI for decades, but in the last 10 years or so, contrast mammo has come to the fore. And both of those tests require an injection of contrast agent. Different contrast agents for both tests. One gadolinium for the MRI, and just regular contrast is called for it's iodinated contrast for the contrast mammo. But what they do is they identify cancers at their earliest stage possible when they have neoangiogenesis, meaning they have little blood vessels that develop around the cancer in order to feed it, in order for it to grow. So we can pick up cancers as small as 3 millimeters and 4 millimeters, which is really not possible most of the time with ultrasound and mammography. So the size of these cancers are important, but also evidence has shown that the types of cancers tend to be that we can pick up on these tests tend to be the more high grade cancers that are the more aggressive cancers. And so those are definitely the ones you want to pick up the earliest possible. Mammography tends to pick up the lower grade, sort of DCIS, in situ low grade types of cancers, whereas the contrast based techniques pick up the more smaller but more aggressive cancers. So those are really the tests, I think, that are really our, Rolls Royce of imaging tests for breast cancer
What do you
detection.
foresee from advocacy groups really putting forward the banner to get MRIs more affordable and more reachable to larger patient populations?
So that's why I'm so enthusiastic about the contrast mammo,
Mm.
because the contrast mammo is just there is a huge installed base throughout the United States of mammography machines. There's not that many MRI machines, so it's a really an access issue. So we've seen in many studies that the contrast mammo can be equivalent or almost equivalent to the MRI in its ability to pick up small cancers. So, and it's also cheaper, and it's also much more tolerated by women than the MRI examination. I don't think we'll ever get rid of MRI, but I'd love to see a shift of women getting more contrast mammo. And frankly, I think probably everyone should be getting a contrast mammogram.
So, would the
And
contrast mammogram be more in keeping with early diagnosis, or would it also allow the surgical team to denote the extent of the disease? Would that
both.
patient need an MRI after the contrast enhanced mammo? That
No,
is
I don't.
what I received.
Well, those, it's still, fairly early days, but the contrast mammo definitely shows the extent of disease that
Great.
is masked by the mammogram. But the benefit of the contrast mammo is that you get not only the contrast information, which is what you would get with the MRI, but you also get the mammogram information as well. So you can find out, are there calcifications there? Are there areas of distortion? Things that you normally maybe wouldn't be able to see so much on the MRI. So all of these tests give you different information, and they're all sort of additive, and one doesn't really, but the closest tests that could possibly replace each other would be the MRI and the contrast mammogram.
I have patients, and I don't know why. I certainly don't have the answer. Over the past 6 months, I have seen the largest number, and coming from several decades at Memorial, I can say I've seen the largest number of 21-year-olds, 23 year
Yeah,
olds, 25-year-olds with node positive, fairly aggressive breast cancer, either triple negative or HER2 new
yeah.
overexpressing. And the ones that concern me the most are the ones that are ERPR positive and HER2 new negative. I
Yeah.
think with the first two, triple negatives and HER2 positives, we have therapy that is actually very
Good.
exciting regarding survival outcomes. What do I say to that patient? I was just with one 2 days ago who was
Oh
23.
my gosh.
How does she? I had a 21-year-old 2 weeks ago, both node positive. The question that I get is, what about my sibling who's 18 years old? Now, a
Right.
gene has not been identified. How do we protect that 18-year-old whose sister was diagnosed at 23? And you may not have the answer, but
Yeah, well, we go to the guidelines
mhm,
in this sort of situation. In general, we will not do a mammogram on someone under the age of 25,
mhm,
just because of developing breast tissue and because it involves radiation and the harm it outweighs the positive. I mean, obviously, if you have a palpable mass and it looks
of course.
suspicious, you would do a mammogram. But I'm talking about just screening and doing, for family members. So we usually recommend, and also the same thing, MRI though can start at any age. You could start it at 18
Mhm.
if there was. If, for example, if a gene mutation was identified and that patient was high risk, and that that 18-year-old could be doing MRIs for screening, but we wouldn't start mammography until after 25. Um, the guidelines, have obviously, changed a lot, and there are guidelines now that say that, at the age of 30, every woman should sort of understand their risk, and but this is, who owns this and who really educates women, because usually at the age of 30, women are, trying to have families, and they're in that stage of their life seeing their gynecologists and not really thinking about breast cancer screening, or the possibility of having a breast cancer. But it's the same thing. I mean, I can't tell you how many times women would come in and, after, they have couple of toddlers at home and they feel a big mass in their breast, and their mother had breast cancer at 40, and you're like, well, how come you weren't, how come no one told you that you needed to be screened much earlier than the guidelines, because of this strong family history of breast cancer? And this sort of information hasn't reached them, that when you have a mother or a sister who has breast cancer premenopausal, you need to start 10 years before that age of that relative to start screening for breast cancer, whether
And
it's
that
with mammography
recommendation has been in place since I got into the
forever.
field 40 years ago.
Yeah,
It's astounding. What I was happy about, not happy, of course, but that at least I was satisfied that both of these young women that I met over the past 10 days palpated a mass and were not, you know,
they were
kind
not ignored.
of, they were not,
Yeah,
they were immediately evaluated and sent for evaluation by their
yeah,
GYN. I will tell you what's heartbreaking is when someone
right,
is poo-pooed, oh, wait 6 months, oh, it's going to go away. It
right.
doesn't happen in somebody who's 25. Yet we're seeing colorectal cancer and breast cancer
Yes,
earlier and earlier ages now.
yeah, yeah. Yeah. So the guidelines are always behind what's going on, and it takes a while for them to catch up. But uh, they still, really don't incorporate contrast imaging techniques either. I mean, they're starting to incorporate the ultrasound just because of this, push, the political push. But contrast techniques, even though it's been shown, there was a great study actually in the Netherlands, and I love that the Netherlands
Oh,
do
the
these.
Dutch study, yes.
Love, yeah, that Dutch study that took average risk women who had dense breasts, and they did, one arm was just mammograms. So the women in that arm only had a mammogram, and the other arm was mammograms and MRI. So they added an MRI, and they found um, in that arm, 16, well, almost seven, it was 16.8 cancers per thousand with the MRI, as opposed to 5 per thousand with only the mammogram, and smaller cancers. And on the basis of that, so these are average risk women. Okay, they're not high risk. So on the basis of that, the Dutch Parliament said women with dense breasts in the Netherlands should be getting screening MRI examination. But it's an expensive exam, and it got blocked because it was going to cost too much money. Those investigators, though, they showed that you don't have to do annual MRI. You don't have to do an MRI every year. You could get the same results if you did an MRI every 4 years. So, you staggered it so that you would at least get a contrast test, every once in a while to make sure that there was nothing brewing or nothing going on in your breasts that the mammogram wasn't picking up.
I think
So,
what is a tragedy for me is that we discount, we say, oh, most breast cancers are found in postmenopausal women. Aging is the one of the highest risk factors. If you get to 85, your risk is XYZ.
right.
But if we look at the mortality, the death
The
rate,
40 to 50-year-old age group is the biggest.
exactly.
Yeah.
We're not talking about less than 40. We're talking about 40 to 50. Those
Yeah.
cost years are huge. I mean, these
Those are the
women who
women.
are at the forefront in their family circles, their community, their professions.
Yes.
They are expensive
Yes.
years that are being lost.
Yes. And so that is the year. And that was the decade that we fought so hard, against the USPSTF about, because that is the decade, if you want to give up screening, okay, over 50 or 60, but the 40 to 50-year-olds have to get screened every year. I mean, the data is clear on that.
And
Um,
those women under the age of 40 who have a family member that was
right.
diagnosed.
They have to be screened. Right. Right. Um, so yeah, so luckily I do want to, I want to say finally the USPSTF came out this last year and finally said that the 40 to 50-year-old age group should be screened, whereas they have held out for decades
Oh my
saying that
goodness,
they
yes.
shouldn't be screened, and it's just a travesty. It really is.
Liz, you have a personal story that I think might be important for some of these patient and family members to hear. I know that you've spoken about it in public before. Um, it's been denoted in literature on the web. Are you comfortable talking about it for the next few minutes?
Absolutely. I'm a completely open book.
Mhm.
Yeah, so I was, at Memorial Sloan Kettering, and I had accepted this job to come to be chair out here in California. And I was but before I went, I had always wanted to have a reduction surgery, just because I had always planned to do that at some point. And so I had done that, and just before I left. So this was December, and I had done it in, you know, late October. And as I was standing for the movers to come and pack up my apartment in New York City, I got a text from my breast surgeon that said, and I was expecting everything was fine and everything. And I got a text to say, I'm really sorry, but in the tissue I took out, they found a 4 millimeter invasive lobular cancer. And I can remember, everyone who gets breast cancer or any kind of cancer knows exactly where they were when they got that, when they were told that they have cancer. And I definitely will have that moment memorialized. And I just was in complete shock. I thought, I do it, I eat right, I don't excessively drink, as you were saying before, But anyway, but I'm a woman and I was over 50 and I was, and those are the two biggest risk factors that you can, or, age and being female are the two biggest risk factors you can have for being, having breast cancer. And we know 1 in 8 women are going to get that in their lifetime. And I
And
was
there's
one of those
something about
1 in 8.
invasive lobular carcinoma that's very different from the most common invasive ductal. Invasive lobulars are often radiographically silent.
So my thing is that I had done, being a breast imager, before the surgery, I meticulously made sure that I had my tomosynthesis mammogram, right? And then I had a screening ultrasound because I knew I have dense breasts, and I did not do a contrast based test. Okay. I didn't want to be, a prima donna and say, I need to, have a contrast imaging before I have my surgery. And I regret that. I wish I had had a contrast because I do feel that contrast test probably would have identified this cancer. So it was undetected on regular screening. So I am, a breast imager that, prides herself on trying to find the smallest cancer possible on all of these kinds of tests. And I and my colleagues completely missed it. And because it was very difficult to see. And this is, I think I'm emblematic of why you want to have contrast based imaging because, the mammogram, no matter how good it is or how the ultrasound, you will miss cancers. So,
Yet,
so
if you
anyway,
had not decided to move forward with that breast reduction,
oh,
a year or two later, we would have
I
been dealing with.
with like a 10 centimeter cancer, who knows? I mean, it's a lobular, they grow and you can't, they're very hard to detect, not only on physical exam, but also on imaging. I'm both on mammography and
Right.
ultrasound. Very tough, very tough. Yeah. So I am very lucky that I had that surgery. Incredibly lucky, but I'm very lucky that the pathologist was paying attention, and looking at all of that tissue. I sent the pathologist a huge thank you note and thank you for being so meticulous and attentive to tissue that you know they see they see all the time, and they probably think, oh,
Right. It's
there's
usually
something going to be
benign
here.
and
This
right,
is a
right.
benign thing, and but this really astute pathologist picked it up. Anyway, so because it was small, I didn't need chemo. I didn't need to see you, Maria. But I did have a sentinel node biopsy, which was negative, and I did have radiation. Yeah. So I
God,
was, so I was, of course, sweating it. But now I will tell you, that was 4 years ago or 4.5 years ago. And I've been doing my MRI screening meticulously every year. And just this week, I went for my MRI screening and I have a new focus, a new tiny 3 millimeter thing in my left breast, which is where the original cancer was. So now I'm very nervous and I am going to have that biopsied under MR, but I'm very nervous. So now I know what it's like as a patient to go get an imaging test and then have results that you don't really know what the results are of. And that's a very, very anxiety provoking feeling, I would say. So
I'm so
it's a
sorry.
journey always.
I'm sorry,
Well, I don't
but
know that
I'm
it's
the fact
anything yet,
you're
but
getting your MRI every year. I can't tell you that how many patients I have with invasive lobular cancers that do not have an MRI audit subsequently every year,
I think they
or looked
should.
at.
I think they
Absolutely,
should. So
absolutely,
so
absolutely.
absolutely. I think breast cancer people who had lobular, and also people who had cancer diagnosed premenopausal or perimenopausal, um, or they have dense breasts and they're really hard to follow up, should all be getting MR for sure. Absolutely.
Liz, I can't tell you how eye-opening and how impactful this session is, and for how many women that are going to be listening to it. I truly believe that your story will change many women's storyline for the
Well, I
better.
hope so.
For the
I hope so
better.
because you do have to advocate, I think, for these tests.
And I pray, and every moment we'll be thinking of you and hoping for a quick resolution to whatever this 3 millimeter thing is. Um,
I'll keep you
you
posted,
know,
Maria.
I normally end these sessions with a joke, but you have me paralyzed right now. So,
It's been
follow
great
up to
talking to you.
come. It's always great seeing you and
Yeah.
talking to you. And obviously, we're going to have a part two to this at the
Yeah,
very least. So
for sure.
we will talk over the next week or so. Everyone, listen to what was said in this program, rewind it and replay it, and talk to your providers. And many of you do not have an oncologist because you haven't had breast cancer, but listen to what you've just heard. I can't tell you how grateful I am to you, Liz, for your transparency, your honesty, and your advocacy. With that, we will close, and I promise you all a part two to this program.
Thank you, Maria.
Thank you, Liz.